Welcome back to the deep dive. Today we're going into an area where the margin for error is, well, it's basically zero. We're talking about pediatric medication administration.
Highest
The
stakes.
highest. We're going to be pulling back the curtain on the just the incredible protocols required when you're treating kids. Every dosage, every route, it all has to be so precisely adjusted.
It absolutely does.
Yeah.
And our mission today really is to pull out the most essential high-stakes nuggets from the source material you sent over, which is mostly based on Dr. Rhonda Wood's work.
Right.
And what you see right away in those sources, I mean, from the training DVDs all the way to the checklists, is that safety here isn't just about being careful. It's about having a system, an unbreakable system.
An unbreakable system that starts with a checklist so thorough, it honestly makes standard protocols look, I don't know, a little basic. That's the first thing that really jumped out at me.
I know what you mean.
If you, our listener, thought the 5 rights of medication were the gold standard, well, you need to prepare yourself. We are diving into a framework that demands 12 medication rights.
It's a total philosophical shift, isn't it? When you go from 5 or 6 checks to 12, you're moving beyond just logistics. You're integrating assessment, ethics, patient response, all of it into the actual procedure.
So it's not just about the moment of giving the medicine.
No, not at all. It's acknowledging that that's just one small piece of a much larger puzzle.
Okay, so let's unpack this framework because it's a brilliant way to formalize total safety. It starts with what they call the core 6, right? The logistical checks.
Right. These are the absolute non-negotiables. You've got the right medication, the right patient, the right time.
The classics.
The classics. Then right route, right dose, and of course, ensuring the right documentation happens right after. That's your baseline.
Okay, that all makes sense. But this is where the system just explodes in scope. The next 6 rights, they move from procedure into accountability, patient autonomy, dynamic assessment. What's first?
The first of that second group is the right education. And this is specifically about educating the patient or, in pediatrics, the family.
Oh, that makes sense.
You can't have safety at home if the family isn't totally read in.
Of course.
Yeah.
The responsibility goes beyond the clinic walls.
Right.
But, okay, I have a question here. The next 2 are the right assessment of the child and then the right reason for the med. Isn't that something the doctor already did? I mean, why does the nurse or administrator have to re-verify those as separate rights?
That is such a crucial question. It gets to the heart of how these systems work. Think of it as a triple check. It's designed to catch last-minute changes. So for assessment, maybe the prescription was written this morning, but now the child's vital signs are different. The symptoms have changed. You have to confirm the medication is still appropriate in this specific moment.
So it's not about what was ordered, it's about what is safe now.
Exactly. And verifying the reason is like the final sanity check. If the order is for an anti-nausea drug, but the chart says the main complaint is a high fever, that mismatch should stop everything right then and there.
Got it. Okay, so what are the last 3?
They're all about follow-through. You need to check for the right response. Did the medication actually work? You need to monitor for the right reaction, so any adverse effects.
And the last one?
The right to refuse. It's critical. Even with kids, you have to respect the patient's or family's right to say no, and you have to document it. It makes the professional accountable for the whole arc of care, not just, the physical act of giving a pill.
That is just so robust. Or
Okay.
safety net. Okay, so let's move from that checklist into the actual operational rules, the really high-risk stuff.
Yes, because after you clear the 12 rights, the system puts up even more walls for high-risk meds. The first rule is an absolute. All medications are directly supervised by an RN or an instructor. No exceptions.
No one's going solo. And speaking of high stakes, the source material had this one really specific ban that stood out. It just said, no digoxin administration.
That one line tells you everything you need to know about the risk level here. Digoxin is a cardiac drug with a super narrow therapeutic window. The line between a helpful dose and a toxic dose is tiny.
So they just take it off the table completely.
Yep. Eliminate the risk.
Right.
Which makes the 2 high alert meds they do allow that much more significant. We're talking insulin and heparin.
And for those, the rules are airtight.
They have to be. For those, you're required to have a 2RN check before administration. The system is openly admitting the lethal potential of one small error.
And for heparin, there was a route constraint too, right?
Yes. 6U only, subcutaneous, which means it's injected into the fatty tissue, not a vein. It's a slower absorption route, which builds in another layer of safety. It limits that immediate systemic impact.
So that dual RN check is the system basically accounting for human error,
Precisely.
building in redundancy. Okay, so we've covered the checklist, the high-risk drugs. Now we get to my favorite part. The real micro-level details, the physical techniques that change completely based on age.
This is where it gets fascinating. You're constantly adapting, like with eye medications. You can't just tell a 2-year-old to hold still and look up.
No.
So the source material has this very specific maneuver, and it's all based on anatomy. For children under 3, the technique is to pull the ear down and back.
Down and back. Why that specifically?
It's all about the ear canal. In an adult, it's sort of S-shaped, but in a small child, it's straighter and angled more downward. So pulling down and back actually straightens the passage for the medication. It's pure anatomic dictating procedure.
Wow. And that detail extends right down to, well, to the size of your finger for rectal administration.
I know, this one is amazing. It just screams operational rigor. We're talking about a rule for insertion depth to make sure the medication is retained without causing injury. For kids under 3 years, the protocol requires using the fifth finger, your pinky finger. And for kids over 3, you switch to the index finger. That strict 3-year cutoff is the margin of safety. It just shows that these rules were written by people who have seen what can go wrong.
I'm stuck on the fifth finger rule. That is an incredible level of detail, but it perfectly illustrates the whole principle. Everything in pediatrics is scaled down.
It has to be. And that's the difference between a general guideline and a true safety protocol.
Okay, let's look at intramuscular or IM injections. Here, the needle length has to be adapted based on what, muscle mass?
Exactly. Mobility and muscle mass.
Yeah.
The gauge, so the thickness, is pretty consistent, 22 to 25 gauge, but the length changes. For newborns, infants, and other small children, you're looking at a length of 58 to 1 inch.
And then as the child gets bigger, more mobile.
Right. Once a child is walking, or generally over 2 years old, the length extends a bit, from 58 up to 1¼ inch. It's a subtle change, but it's critical for hitting the muscle properly without hitting bone.
It's just layer upon layer of specificity, which I think is a perfect setup for our final section. Specialized delivery systems, the tubes and buttons.
Right, the enteral access devices. This is a highly technical area, and the source lists out all the different types you might see. You've got your nasogastric tubes, or NGTs.
Down the nose.
Yep. Then gastrostomy tubes, GTs, which go right into the stomach. Jejunostomy tubes, or J tubes, that go into the small intestine, and even some combined JG tubes.
And it's not just one kind of tube. The actual hardware, the part you see on the outside, can be totally different.
Exactly. And the hardware dictates the procedure. The source lists things like a Ballant type, a Pessar, or Mushroom GT, and then the more modern gastrostomy button, or the McKee button.
So identifying the specific device is a safety check in itself.
It's critical. A McKee button connects completely differently than, say, a standard Foley type. You have to know what you're looking at.
Which brings us to the actual procedures for using these tubes. What are the non-negotiables?
Well, first and foremost, you have to check placement. Always. Before anything goes in that tube, you must confirm it's still in the right place, in the stomach or intestine.
And after placement is confirmed,
You flush the tube. The source notes that there's a difference between feeding versus medications, which suggests different protocols for each. And importantly, you flush with sterile water. You have to maintain that sterility.
And the physical handling of the device is part of the protocol too.
It is. They specifically mention proper use of syringes and what they call button use. It just underlines that safe administration isn't just about the drug. It's about mastering the dose, the patient, and the device.
We've covered such an incredible amount of detail here, from the 12 rights all the way down to, choosing between your index finger and your pinky. It's a system built on just extreme precision.
Absolute rigor. And, if you look back at the source material, there's one final, almost throwaway line at the end of all this. It just says, practice math.
Practice math.
Yeah. And you have to ask why. After all this procedural detail, why is math the final safety check?
Well, it has to be the dose, the right dose. That's one of the original 6 rights. And in pediatrics, the dose is almost never a simple number. You have to calculate it based on weight.
Exactly. Mathematical accuracy is the hidden 13th component of safety. It ties this whole massive system back to one single calculation. And if that calculation is wrong, all 12 of the other rights, they don't matter. A tiny math error could be catastrophic.
That's a fantastic point. Math as the silent 13th safeguard. And as you think about that, about all these layered checks for drugs like insulin and heparin, the supervision, the 2-person sign-offs, It raises a pretty big question for you, the listener. If heparin requires 2 certified RNs to double-check a capulation, what unseen risks are we all just accepting when we self-dose powerful adult medications at home without a fraction of that mandatory rigor?
That is a very powerful point to end on. The contrast is,
Yeah.
it's stark.
Thank you for joining us for this deep dive. We will catch you on the next one.